Hello, everyone. My name is Brian Carey, Vice President of Marketing here at Unbound Medicine. Thank you for attending our webinar titled, Are You Prepared for the New Antimicrobial Stewardship Standards? This webinar will be about 30 minutes in length with some brief time at the end to answer some questions. Please submit them in the questions window. If we don't get a chance to answer your question during the live session, we will email you after the webinar is complete. First, let me tell you a bit about Unbound Medicine. Unbound builds digital products that answer clinical questions at the point of need. Our dedicated and experienced team has delivered innovative mobile and web solutions to healthcare institutions and individual clinicians for more than 15 years. Now I'd like to introduce our presenter, Dr. Paul Auwaerter. Paul is the Sherilyn and Ken Fisher Professor of Medicine at the Johns Hopkins University School of Medicine, serving as the Clinical Director for the Division of Infectious Diseases and Director of the Sherilyn and Ken Fisher Center for Environmental Infectious Diseases. He serves as the Executive Director of the Johns Hopkins Point of Care Information Technology Center, producing the Johns Hopkins ABX, HIV, OSLR, Psychiatry, and Diabetes Guides. This year, he's serving as the President-elect for the Infectious Disease Society of America, the largest professional society worldwide related to infectious diseases. Now I'll turn it over to you, Dr. Auwaerter.
Oh, thank you so much, David, and thank you everyone for listening this afternoon. Antibiotic stewardship programs has become a hot topic in the infectious disease world and for many health institutions, mainly since we've had 75 years of modern miracles, that's antibiotics, that have really revolutionized healthcare, of course, but with the extensive use of antibiotics, this has really set the stage for some of the problems which we're grappling with today. So under today's agenda, I thought we would just touch on a couple of key things that may be important to your clinical practices, your care teams, or if you're in information management or medical library world, what things may be beneficial for the people utilizing your resources. So we'll touch on some standards, some of the core elements of antimicrobial stewardship. Let's see here. How teams may be in compliance to help with some of these newer standards, how some of the things that I've been involved in with Dr. John Bartlett now for almost 18 years may be helpful. And if David's listening, I'm getting repeated messages that a maximum of 101 people have joined the webinar. Moving on, let me just paint a couple of foundational areas for people that may not be as familiar with what's driving the requests for antimicrobial stewardship. You know, as I mentioned, we've had 75 now plus years since successful treatment of the first person with penicillin and saving a life in the early 1940s, but with unopposed antibiotic use, not only in healthcare environments, but also often in animal husbandry and elsewhere. We're really grappling now with some of these consequences of success. This slide shows some estimates now that that are now over 3 years old, but estimates were that over 2 million illnesses are accountable to antibiotic resistance. That's not only such pathogens such as MRSA, but resistant gram-negative infections with over 23,000 deaths, and this is thought to be a number that's only higher now contemporary. Another collateral damage area is Clostridium difficile, which many of you may be familiar. This is a pathogen which really arises as a consequence of antibiotic therapy, which sort of changes the flora, the normal healthy flora of bacteria in our colon, allows this particular pathogen to sporulate and produce toxins that really creates an intense burn. This too, over 250,000 cases per year with 14,000 deaths. This kind of environment really has prompted recognition President Obama has created a task force to deal with antimicrobial resistance approximately 2 years ago. And just this past September, the United Nations, really for the fourth time ever, had a high-level meeting and declaration of global health problems similar to TB or HIV, and that is antimicrobial resistance. Some interesting facts at a very high level for everyone is that about half of individuals in hospitals actually receive an antibiotic. And when surveys have been performed looking at prescribing patterns, there are certain doctors that prescribe antibiotics much more heavily than others. And these are some of the key people that stewardship programs are hopefully trying to help identify, counsel, and direct towards prudent and really optimal antibiotic prescribing practices, mainly because it's been seen and acknowledged multiple ways that if you can reduce antibiotic use, narrow it, and really use what I call the Goldilocks approach to antibiotics, you want to use the amount that's just right, you can really probably not only lower the drive towards producing more resistant organisms, but also avoid consequences such as Clostridium difficile. I always like pointing out one particular area. It's not in the United States, but just as an example of how stewardship can really affect change. So the United Kingdom had terrible problems with Clostridium difficile. They had 110 cases per 100,000 people per year. That's about 10 years ago. So 110 cases per 100,000. And because they have more of a centralized health structure, they essentially issued an edict to every hospital administrator that you will be fired unless you lower your C. diff rates. And how they did that is through prudent prescribing. They really enforced a stewardship program to avoid the biggest drivers to Clostridium difficile. And those were drugs in the fluoroquinolone class like Cipro, second and third generation cephalosporins, and clindamycin. So in a really rapid period of time, the number of cases dropped dramatically from 110 to only 25 cases per 100,000. It's been harder to get below that, but this is a more than fourfold reduction, which was really quite impressive and really points to how if people have good health practices that you can really have subsequent health improvement. And I'll mention that all this was accomplished without any problems in terms of people suffering from not using those antibiotics. So as an infectious disease physician, or really any clinician, I think anyone who uses antibiotics in the hospital, you go through a couple of steps where information, I think, is quite important. That is, what is the patient's presenting problem? What do they have? Do you have a differential diagnosis? What are the key leading problems, especially if they're severely ill? What do you most want to target? You then make some decisions on what we would call empiric antibiotics after perhaps you've obtained appropriate diagnostic information. And then there's a reassessment period that classically is about 48 to perhaps 72 hours, where you should really reassess whether the person is on the right antibiotic and be narrowed so you're not affecting so many bacteria that you don't really need to treat. And then what is the duration, and so you can get a durable cure without treating too much or too little. So those are some of the key factors. A lot of interest in antimicrobial stewardship really has arisen from two areas. The first I'll mention, which is a little bit on hold, is that CMS had articulated that antibiotic stewardship is an important component to now healthcare in the 21st century, and they wanted to make it a condition of participation. Those comments and standards are on hold. It is very similar to what has been organized several years ago in the state of California. Regardless, the Joint Commission, for which most healthcare institutions seek accreditation, has asked and required since the start of this year that antibiotic stewardship programs are now outlined and effective in each institution for which they survey and accredit. And a lot of this is because of the recognition that a substantial proportion of antibiotics are either not needed or not appropriate in terms of their spectrum activity, meaning they're doing more than they ought to. And it's the acknowledgement that really education is important, not only to clinicians and pharmacists, but to also have a basis so people feel comfortable in an evidence basis for treating infections. So this particular slide might be a little out of, maybe should be ordered a little differently. So, you know, for ASP programs, that's stewardship programs, there's really a sense that if possible, infectious disease clinicians should probably help lead that program, but this is also probably best accomplished with pharmacy staff, who of course are there and present and quite instrumental on many angles. And in fact, in many institutions where there may not be ID clinicians, they will really be the keys to helping outline a stewardship program. And the emphasis, of course, is trying to do some tracking, looking for quality improvement, making sure laboratory staff are organized to help render antibiotic susceptibility information that might be helpful, and there are many tricks there. If you have EMR, which many institutions now do, that's another component, as well as in-servicing nurses and so on. So for many stewardship programs, one of the key things is trying to understand what are some of the most common infections for which advice is asked, where antibiotics are used, and how those might be best, I won't use the term standardized, but the recommendations are most appropriate there. And acknowledging that this can only be done if there's good local surveillance from either a hospital or community basis, so people know which antibiotics will probably be most effective, for example, against E. coli, for example, in urinary tract infections. I'd also emphasize that an accurate diagnosis is also very important as best as possible. That's not always possible when we start seeing patients. And you'd like to use a narrow spectrum drug, of course, not sacrificing any bad outcomes. Another component that I think is important is just feedback with stewardship programs. So you can actually track, let physicians optimally know what antibiotics they are using for which indications, and how that might jive, for example, with how many other programs or institutions do as a whole. And that would really target some of the practitioners that are perhaps a little further beyond the pale. So I'd like to just pivot a bit to the Johns Hopkins Antibiotic Guide, one that John Bartlett started a bit as a visionary with the Palm Pilot, for those of you that remember the Palm Pilot many years ago. The key here was to try to render information that was practical, concise, and you could find and help take care of patients in real time without having to do too much diving into deep textbooks or PubMed or other recommendations. It was really developed to be as comprehensive as possible, but easy to read, utilize. Really the key would be to get in and out in about a minute once you're used to using the guide. And this was available on smartphones nowadays, also on the web. And we do use, when possible, an evidence basis. It's referenced and peer reviewed. So, you know, for an example, a 72-year-old was hospitalized, had surgery, but had an indwelling Foley, develops a fever and a urinary tract infection is suspected. Is ceftriaxone the right drug in this situation? And there may not be a clear-cut answer at this point, but a stewardship program would really outline a couple of choices for you. But if your institution doesn't yet have a stewardship recommendation, I think something like the Antibiotic Guide can give you a menu of potential things that you could incorporate into a stewardship program, both from a diagnostic standpoint. Here on this screen, you can see all the way on the right-hand side some real practical information on when you might suspect a catheter-related urinary tract infection, and also when you might really want to grade things a bit differently based on severity of illness. These are things that are usually quite easy to search for. There are drugs that are recommended. So someone that's quite ill, you can see on the left-hand side, there's a variety of drugs that are mentioned, along with some other possibilities in the middle screen. We also like to give some quick advice as if you might have an ID consultant right next to you. Why would you use ceftazidime? And most times people would just give one or two quick mentions in this setting, and that's really what we try to capture, to give sort of a real clinical flavor to it, not just a bug and drug guide. And then we also have recommendations. So if there's existing guidelines that are evidence-based, for example, from the Infectious Disease Society of America or elsewhere, we will incorporate those, or if there are not, we'll usually look to some excellent review articles from authorities in the field, or even incorporate guidelines from other countries if they look very reasonable and are ahead of us here in the US for providing information. Other things, just from a familiarity basis, for example, we do have an entire section. We have over 700 modules on surgical prophylaxis. So this again speaks very much to antimicrobial stewardship, to try to help be very effective in providing prophylaxis, but not give in to over-treatment. Here is an example in this screen. In the middle, you can see a number of potential surgeries that maybe anesthesiologists, pharmacists, surgeons might have questions. If you toggle head neck surgery, for example, we say that prophylaxis is not recommended. And this is based, again, on the 2013 guidelines from the American, from the pharmacy group. And if you look at the interventional radiology section, for example, you'll see a number of recommendations that will sort of help people know what you have to do, and it's already outlined. And these are mostly adopted from the Johns Hopkins Institution and or existing evidence. We often have easy to navigate sections to drill in a little more, so you could sort of also just look at commonly used drugs for surgical prophylaxis here, recommended doses, half-life, and redosing recommendations. We really tried to make this as practical as possible, and here you can see it's acknowledged from the guidelines published now a few years ago. Drug modules, we really cover all drugs licensed, or I should say approved by the Food and Drug Administration in the United States. For those of you who might be calling in from Canada, Mexico, or elsewhere, we also generally have any drugs that are used worldwide, so that's available as well. We usually have customary dosing. We have renal dosing, pediatric dosing. We have a section on drug interactions that are very practically based. We try to gauge adverse reactions to a real clinical utility and calling them either common, occasional, or rare, rather than trying to give percentages. We do have fairly thorough PK/PD information for pharmacists and other interested parties, and offer a spectrum of use, so you can see which pathogens are considered typically treated on either first, second, or third line basis. This is a little more subjective based on our own infectious disease clinicians and microbiologists, but can give you a sense for how this drug sort of plays out in many areas. I'll close by another example, one that comes up quite frequently in terms of diagnostic uncertainty, and that is Lyme disease. And here again, we have modules of information that try to help the clinician understand how to use, how to diagnose it, but based both on clinical presentations, but also serology. We do include photographs when appropriate, not only of patients, but also of pathogens. But here's an example here of a classic rash of Lyme disease. And then we try to make this very practical. And here on the left panel, you can see what's not recommended. We don't recommend repeat testing. We don't recommend, unusual alternative medical therapies like hyperbaric oxygen and cholestyramine and chelation therapies. we do give recommendations for how to diagnose the different possibilities of how Lyme might present itself, and of course with drug and treatment recommendations. So in closing, and to allow time for some questions, the Joint Commission recommendations for a stewardship program went into effect earlier this year, and of course institutions will need to have this. The antibiotic guide, I think, can provide a foundation for helping clinicians in many aspects, not only in diagnosis, but also in treatment in terms of drug choices and duration, and in an easy and quick way to find that information while being involved in patient care. Many have used this as a foundation basis for developing their own internal antibiotic stewardship programs and as an adjunct, because often stewardship programs can't handle every known possibility, but only the most common ones, and a guide such as this covers a much broader range in terms of clinical care. So I wanted to thank everyone for listening. We do have time for questions, and I think, David, you were going to be the moderator.
I do have a couple questions that came across, and thank you, Dr. Auwaerter. That was excellent. The first one is the screens that were kind of shown during the presentation were on the mobile device. So the question is it also available for tablets and on the web?
So the answer is yes. These platforms, and one of the reasons we at Johns Hopkins have partnered with Unbound Medicine is they really have kept the technology pieces of this up to date. So it works very well on all mobile platforms, including tablets, and also on computer terminals and screens. So it can be viewed in a variety of ways.
Fantastic. The next one's also about the guides themselves, and just asking, you mentioned how they're updated, but how often are they updated?
So every guide is much like a textbook, undergoes a major update every 3 years or thereabouts. However, for anything where there's been a major change, either a pivotal study, a new guideline that's released from a major society, those usually are updated closer to real time, usually hopefully within 4 to 8 weeks of that release of either the study or major guide. So we really want to try to keep this practical and as current as possible, so that clinicians really are afforded the best and most modern information for trying to help make decisions for their patients.
That's great. And I have one more, just asking, is the information presented in the modules, are they peer-reviewed and or evidence-based?
Yes. So we make all efforts to make them evidence-based. For those of you that actually do a lot of infectious disease treatment, you know that there's often areas where we don't have very good information or studies or retrospective or case series. So as I mentioned, we try to always use guideline information if possible, and really use the highest level qualities of evidence like randomized controlled trials to help inform the recommendations that we make. There are certainly conditions for which we make recommendations where there isn't great trial information, like septic arthritis, and that's where I think we incorporate information from as best as possible from studies and from our own real clinical experiences over the years. So if there really is a real lack of information, you'll actually see us acknowledge that and say this is author opinion when there really is not enough information. So we try to be as transparent as possible, but each module will have each pathogen diagnosis module will have a basis of recommendations, so readers are aware.
Excellent. Well, that's all we have for questions for today. I would like to thank Dr. Auwaerter for his time and his excellent presentation. As I said in the beginning, anyone that does have some questions that want to follow up in the next couple of minutes, we'll make sure that we get those questions answered via email. and we'll get them to you as quickly as possible. We'll also be following up with not only everyone that was on this call live, but also anyone that signed up or wasn't able to get in with the video of this presentation with audio from Dr. Auwaerter, as well as the slides. So I'd like to thank everyone for attending the webinar today, Dr. Auwaerter, and I hope you all have a wonderful day and weekend. Thank you.
Thank you. Goodbye, everyone.